Well, good morning, everyone. Welcome to Pediatric Grand Rounds. And Dr. Permerschwag cannot be here today, so it's my pleasure to introduce our speaker. So our speaker shouldn't be unknown to most of us, but a few of you may not know her. This is Dr. Keele, and she's one of our pediatric intensivists and the pediatric quality officer for the Department of Pediatrics and Clinical Advancement and Patient Safety here at Carilion. So if you don't know her background, she recently has received her master's degree in patient safety and healthcare quality from the Johns Hopkins Bloomberg School of Public Health. And that was an international program, so that's a big deal. So has a very nice background in patient safety. She also completed her pediatric critical care fellowship in primary children's in Salt Lake City, Utah, and her pediatric residency at Cincinnati Children's in Cincinnati. In addition to her focus on patient safety and healthcare quality, she is interested in end-of-life care, bioethics, and pediatric palliative care. So, looks like you're going to give us the alphabet soup of patient safety.
That's right.
Thank you.
Good morning. I'm exhausted. I don't know how everybody else is, and I don't know why I am exhausted because I haven't even been working in the ICU. But okay, this is going to be incredibly interactive, so be prepared. So I did a similar lecture for the residents, and they, I think, felt tortured, and I had a blast. So I decided this is what I would do for Grand Rounds this morning. So first of all, in medicine, as we all know, we love to shorten everything possible into a few little letters. And so I thought I'd go through first a couple of definitions. I always forget to turn this. Is it? It's not working. There we go. So we're going to go through some definitions and then kind of dig deep into some of the really difficult definitions for our healthcare associated infections. We're going to review our SPS data and then just introduce you to some of the projects that we're doing to try to improve our numbers at Carilion Children. So hopefully most of you have heard at least of the 6 dimensions of patient safety. So it's STEEP, and the first one is safe care. So our goal is to always prevent harm, but at the same time improve outcomes. We also want to provide timely care. So reducing wait times, reducing delays, trying to get patients seen in outpatient clinic as soon as possible, get patients from the emergency room up into a hospital bed, things like that are what are involved in timely care. And then we have our 3 E's, effective care, efficient care, and equitable care. So the effective care is making sure that we're using evidence-based guidelines for as much as we possibly can. I know this is somewhat difficult in pediatrics. We don't have as many evidence-based studies to base our practice on, but also to limit overuse, underuse, or misuse of services, which is really important. I came from one of my previous partners at my previous institution in the ICU got Q2 hour blood gases on every patient, no matter what. And I used to laugh at him because I'm like, we're in a really big ICU. We had lots of patients, and I was like, there's no way you even have time to follow up on those every 2 hours. But it was like one of his core beliefs. So he did it no matter what and did not vary from it. Poor child that has to get poked every couple hours. But anyway, but then there's also the risk of underusing those services too. So we have to be really careful to find the right balance. Providing efficient care, so avoiding waste, insufficiencies, and then equitable care. This is a really big push, as you all are aware. We have a lot of healthcare disparities, and so this is a primary focus for SPS, which I will define later, but just in healthcare across the country. And then our last one is patient-centered care. For us, that's not just our patient, but including our families, and trying to really dive into what their preferences and values are so that we can target our care to that. So then HACs versus HAI. So we have our hospital-acquired conditions and our hospital-associated infections. So they fall, you can see the division there. Most of these things we follow and have to report to our reporting body, which is the Solution for Patient Safety. I just assumed everybody knows what SBS is. And then I was just speaking with somebody a couple days ago, and they had no idea. They had not heard of this. So I thought it was really important for us to go over what they are. So the Solution for Patient Safety, it was started in Cincinnati. It's based in Cincinnati. It's a coalition of over 145 hospitals now, children's hospitals specifically, across the United States and Canada. Their goals are to decrease rates of things that cause harm to our patients, to improve safety culture, as I mentioned, identify and eliminate healthcare disparities, and just provide learning systems for ambulatory safety. Ambulatory care is one of their new focuses this year, and so we're joining that part and hoping to kind of join in with some of the work being done in the ambulatory setting. And then their mission, of course, is to work together to eliminate serious harm across children's hospitals. And they actually, this is the system that helps us with national benchmarks. So benchmarks are ways for us to compare ourselves to other children's hospitals across the country. This is our kind of benchmark data. There's a lot of information there. We're going to go through each one of these in more detail. So I know it's small. I know you can't see that, but this is just some of the things that we follow. We follow adverse drug events, CAUTIs, CLABSIs, PIVs, things like that. So NHSN, this is the National Healthcare Safety Network. This is sponsored through the CDC. And it's actually the healthcare associated infection tracking system for the nation. But as you can imagine, that's primarily adult hospitals. So, and most of the benchmarking that happens on the national level is for adult hospitals. It's not, it's through CMS, which is why SPS is so important for us, because it really helps us identify what we should be doing as far as a children's hospital and comparing ourselves to other facilities similar to us. The NHSN serves over 25,000 medical facilities, and it provides the definitions for all of our hospital associated infections, and these are the definitions that SPS will use and that we monitor and track all of our infections with. So these definitions are difficult to understand. So this is the interaction part of this talk. So I thought it would be really fun, it is fun for me, to go through whether or not something is a CAUTI or a CLABSI or a ventilator-associated event, and just see how much you guys know. So, first one, 10-year-old has a Foley in place for 2 days and then develops a fever. Urine culture is sent and grows greater than 10 to the 10 E. coli. CAUTI? Okay, I'm just gonna do hands. Yes?
I'll say no.
Okay, no? No. It is not a CAUTI, because the Foley has to be in place for more than 2 days. So good job. 1-year-old with a Foley in place for 4 days. Foley is removed for 3 days, and now has a new Foley. Overnight has a fever and a positive urinalysis. CAUTI? Who says yes?
Just because the other one was no.
The other one was no. Oh, you do not know me well. The answer is no. If it's been discontinued for 24 hours, then it starts completely over again. And he has not had a new Foley for more than 2 days. So, does this mean that we did not give this child a urinary tract infection? No, it doesn't mean that. It just means that we are not going to get dinged as a system for having a COTI. So I think these are really important things to understand. And this is, I find frustrating because a lot of times we'll focus just on these numbers and not what's happening underneath it. And this kid was in our care for at least over a week, didn't come in with a urinary tract infection, now has probably a urinary tract infection. And it probably was because they had a Foley in. So we should probably still dive into that, figure out what we could have done better. But a lot of times we focus just on those numbers and, oh, you know, we don't have a COTI, it didn't count. So there's the spirit and the letter of the law kind of thing here. So for it to be a COTI, you have to have 3 criteria. The first we've already talked about here. So you have to have the presence of an indwelling catheter for more than 2 consecutive days. And the event has to happen on the day that it's either the day of the event or removed the day prior to the event. So it can't be more than 24 hours since the Foley's been removed. Okay, 12-day-old with Foley in place for 4 days, was removed yesterday, now has an apneic event. Urine culture was sent and grows E. coli.
What time is it
In
now?
24
What time of
hours?
day was it yesterday?
It was removed yesterday. Let's say that this is at 9 o'clock in the morning. So it was removed at, I don't know, 4 p.m.
Yeah.
You're going to make me remember if I said yes or no. I don't know. No, this was yes. So this definitely counts because it was removed just the day before the event. And then, so this is the criteria too. They have to have some type of a symptom. So you have to have at least just one symptom of the ones listed. The ones that are in green are the requirements if you're less than 1, mostly because you know, it's hard for a 8-month-old to tell you that they have urgency, frequency, or costovertebral angle, you know, tenderness. So in little ones, they can be either hyperthermic or hypothermic, have apnea, bradycardia, lethargy, or vomiting count for them. So if you're 2 and your only symptom is vomiting, that's not a criteria. Make sense? Okay. 17-year-old, Foley's in for 2 weeks. That should never happen. Just kidding. Sometimes it happens. Urine culture sent and grows candida. COTI? Who says yes? Okay. Who says no? Be brave.
The Canada throws me off
Oh,
from the
does
last
it?
lecture.
Oh, interesting. Yes, Candida does not count as a COTI.
Maybe a nasty COTI.
Wow.
Yeah. Okay. 5-year-old with a Foley. Urine culture sent grows 3 species of bacteria and 1 fungus. COTI? Anybody say yes? Oh, no yeses in the room. Okay. It is a no because you cannot have more than 2 species. So here's your 3rd criteria. The patient has a urine culture with no more than 2 species of organisms identified, and at least one of those must be a bacteria. And here's a list of the excluded organisms. So if you have any of those, it does not count. Dr. Keys, you're shaking your head. Why?
He hates weirdness.
No, I mean, but Canada, you can't have Canada in the urine.
You absolutely can.
That's not always a contaminant.
it's not always going to count. It can be absolutely a true infection. It just doesn't count as a clotting. The reason why is because they were having so many clotties in women. And it's just because women have much higher rates of candidal infections, and they were true infections, but not necessarily caused because of the presence of a clotting, of a Foley. I know, it's a lot, right? I know. When I was learning all this, I was just like, this is crazy. I used to argue, earlier on before I did all
The
of my
numbers are too high, you change the definition, so your numbers will be lower.
politics.
Yeah, and women have Candida in their vaginal flora, not in their bladders.
Yeah.
If this is a Foley, it's coming from the bladder, not the vagina.
Well, I think what they're saying is that it probably came from the vaginal area and then moved up the Foley into the bladder.
But isn't.
I know, I know.
Yeah, isn't that how the E. coli gets?
Yeah. I was gonna
That is how the E. coli got there too, absolutely.
It was by hematologic spread, it would have nothing to do with the catheter.
Yeah.
Absolutely.
So then shouldn't part of the definition be a certain outcome, a certain observation, negative patient effect, a certain morbidity then to add to
Yeah,
that?
so we all know that any of these hospital-acquired infections increase length of stay, increase morbidity for patients. But I think, it's a balance, right? You want to make sure that you're preventing everything you possibly can prevent. And the people who worked on this decided that these things are too difficult to prevent, and so they shouldn't be marked against a hospital. So that's part of it, right? Like initially this started as just, we're going to eliminate all of this. And then they started looking into it and realizing there's some things that are just kind of potentially difficult to prevent. And in the adult world, the hospitals they get dinged and they lose reimbursements for any treatment if it's actually one of these hospital-associated infections. So, it's a balance. And like I said, it doesn't mean that there's not room for improvements. It just means it's not going to count against us. So that's why I think these definitions are very interesting and important to know. I've had patients that one story I will tell you during the lovely beginning of COVID when all of the adult hospitals were just run over. We actually had a 19-year-old that we took from an adult hospital to our freestanding children's hospital to care for that was really sick. We'll learn as we go through for ventilator-associated events. In children, they look, the definition deals with your mean alveolar pressure, so your MAP on your ventilator. In adults, they look at PEEP. And my patient was spontaneously breathing, so I had her just getting PEEP. And she was just, ventilated, but getting PEEP. And she got an infection. After being there, she was still in the midst of her COVID getting better, but she actually got a MRSA infection. Her PEEP went up. Our hospital refused to even look into it because her MAP didn't go up because I had her breathing spontaneously. And so it didn't meet the pediatric definition, and we were a pediatric hospital, and I was like, but this is an adult, a 19-year-old. We took from an adult center. Based on their definition, she would have a VAP, and we should look into this. And I couldn't convince them to have us, dive into this and figure out, because we gave this person a MRSA infection. So, so these can be, I think they're really important. It's nice to have good, beautiful numbers, but it's important to remember that this is just the letter of the law, and that there's something more behind that. And it doesn't mean that we shouldn't be investigating these things if somebody does get a candidal infection and they had a Foley in, we should probably be investigating, like, did we not do the right care? What could we have done to prevent it? Okay. 7-year-old, Foley's in place for 3 days, has Staph aureus bacteremia, so you already know that. It was identified 2 days ago, antibiotics were started. The nurse tells you that his urine is looking cloudy. Does he have a CODI?
Nope.
No, why?
Probably doesn't mean anything.
Okay. UTI cannot be considered secondary to another infection, and so you're not going to even send a culture. Doesn't matter. Doesn't matter. In fact, our hospital's very strict on, like, do not send a culture. If you already have an infection that you're treating somewhere else and they have a Foley, just don't send it. And then remove the Foley if you can. So primary prevention is to discontinue the Foleys as soon as you possibly can. Do not keep them in. And then secondary prevention is our insertion and maintenance bundles that our nurses know very well. Our current CODI rate is 0. And then I thought I'd go over real quickly what SIR is, just in case people don't know what that is. So it's a standardized infection ratio. It compares hospitals' actual infections to the predicted number of infections that they should have. So just because we'll be looking at standardized infection ratios as we go through this. Okay, CLABSI. So just a little note, the safety manual that has all these definitions for CODI, for ventilator-associated events, is usually is about 10 to 15 pages long. The one for CLABSI is 48 pages. So it's a lot of stuff to kind of try to get through. And so I just want you to keep that in mind. I tried to slim it down as much as possible without giving you way too much more information than you really wanted to know. So they define what a primary bloodstream infection is. So this has to be a laboratory confirmed infection that's not secondary to any other infection in the body. They define what central lines are. So they count any permanent central line. So whether this is a tunneled or implanted catheter, so Port, Hickman, Broviac, dialysis catheter, a temporal or temporary central line. So those are all, our normal CVLs, PICC lines, and an umbilical catheter. For a CLABSI, the line has to be in place for 2 consecutive days prior to your event, and you have to have a recognized bacteria or fungal pathogen that it's not due to an infection somewhere else. So I kind of cheated and gave you some definitions this time. Let's see if you can still figure out the answers. 10-day-old in the NICU has umbilical lines that were placed at birth. UVC was pulled back to a low-lying position on day of life 4, and they have a peripheral culture that's positive for Staph aureus. Is this a CLABSI? Who says yes? Okay, we got some
I say
yeses.
no.
Huh?
I'm sorry, I say no.
You say no.
No.
Okay, who says no? It is a central line infection. So it is a CLABSI. So even though you repositioned it, it doesn't matter if it started as a central line, it's a central line until it's removed from the body. And it's been in for more than 2 days. And it's Staph aureus.
So the culture doesn't have to come from the line.
The culture does not have to come from the line, no. Which I'm so glad you bring that up because I've got several slides about where we're drawing cultures from. So 13-year-olds with ALL, they have a port. They're admitted to the PICU with hypotension. 2 days after admission, the cultures that were drawn at admission are positive for Pseudomonas. Is this a CLABSI? You all act like I'm trying to trick you here.
You
Because everybody's like,
You'd worry that it's a line infection, but is it a CLABSI in the definition that the hospital gets advanced?
It's
Because it was drawn on admission.
You bring up some really interesting, excellent points. It is the CLABSI. It doesn't count against the PICU because it's not something that they got in the PICU, but it is going to, it should be investigated because you need to find out. So this was a port, right? So we need to find out the last time it was accessed, where it was accessed. If it was in our HEMOC clinic, then that's an outpatient ambulatory CLABSI. And so it will still be a ding, it should be a ding against our system. We haven't really been tracking that, so we wouldn't have it as a ding against our system, but it really should be. But it's not going to count against the, the PICU, didn't get a CLABSI or anything like that, but it is considered a central line infection. 5-day-old with umbilical lines and a blood culture that's positive for GBS.
When was it drawn?
It was drawn at day of life 5.
How long have the lines been in?
Since birth.
With the definition of class, it would be a yes
You would say yes, okay, because it's been in
for more than 2 days.
for more than 2 days, and it's a regular, it's an identified pathogen, right? So no,
GBS.
it is not. So GBS comes from the mom, not from the baby. Do you see why I enjoy this, but everybody else thinks this is torture? Okay, so until the child is 6 days old, any GBS infection does not count. After 6 days, it starts, like if they were day 7 and had the cultures drawn at day 7, it would count as a CLABSI against the
And
hospital.
is that day 6 to 7 the definition between short term and latent versus early onset?
Yes,
all right.
probably, yeah, this would be, yeah.
Okay.
They just consider that at 6 days of life, any GBS infection should already be, been taken care of.
Okay.
That it would be from us if they got it after that point. 6-month-old who had a right IJ in for 4 days. It was removed, and 36 hours later he has a fever, blood cultures are drawn, and they're positive for gram-positive cocci.
Yes.
We've got some very strong yeses. The answer is no. Central lines are eligible for CLABSI events until the day after removal, sort of 24 hours after removal, or patient discharge, whichever comes first. So no, sorry, it's been 36 hours. Now, did we give them a bacteremia and a line infection? I mean, the infection was probably from the line. We probably did that. But again, it doesn't count against us. We don't count it as a CLABSI, but we probably did something to give this child an infection. So, 8-year-old on ECMO has an arterial line, develops a bloodstream infection.
No.
Why?
Heart lines have a low infection rate.
Yeah, I don't
And
think
it's not a central.
So arterial lines, you're right, and ECMO cannulas, even these great big huge things, do not count. They do not count. So the only arterial things are a UAC or a PA cath. Those count as central lines, but arterial lines otherwise do not. VADs, peripheral IVs, midlines do not count as CLABSIs. Now, I've never taken care of an ECMO patient that doesn't also have a central line. So the real scenario is this patient has a central line, arterial line, and ECMO for 2 days, and yes, that would be a central line infection. But without that central line, you can't, the ECMO cannula does not count. Blows my mind, as it looks like yours is blown as well. Okay. 14-day-old with a femoral CVL has a positive blood culture for Staph aureus on hospital day number 6. He's documented to have a CLABSI, so he has a CLABSI. We got a ding. On hospital day 12, he has a new fever, new blood cultures are grown, and they're positive for Pseudomonas. Does he have a second CLABSI? Did we give him a second CLABSI?
Do they still have the normal line?
Same line, they're not gonna count it.
Same line, you're not gonna count it.
We did it, but I bet that's the rule.
Yes, so no. So there is this little thing called a repeat infection time frame, and they define it as 14 days. So if you get a CLABSI, if you're counted as a CLABSI, and it does not matter what happens for 14 more days, you do not get dinged. They can have 3 different infections, it doesn't matter. It's similar to that 6-day GBS rule for the infants. You know, that's kind of their infection time frame. So, but for CLABSIs, it's 14 days. So 2-year-old has a PIC line, symptomatic UTI, and we found out that they have enterococcus on hospital day number 10. On hospital day 12, the blood culture is also positive for enterococcus. CLABSI? Very good. It is not, because that bloodstream infection, they're going to consider secondary to that UTI, and it cannot have a secondary source, or cannot be from a secondary source. Same patient, on day 15, blood culture grows Staph aureus. People are saying yes, yes, because it's a different organism, so we know that that didn't come from the urine. Good. See, I wasn't being too mean. Okay, so how do you draw, or for the doctor's order, doctors, nurse practitioners, how do you order a blood culture according to Carillion's policy? 17-year-old has a PIV, a right IJ, and an arterial line with a new fever. Where do you draw the culture? These are your options. I want to see 1, 2, 3, or 4. So everybody has to answer. Put your hand up and tell me where you're going to draw that culture from.
I want 2.
You can't pick twice.
I want 2, yeah, I'm with you, Virginia, I'm with you, I want 2.
Everybody's like,
Yep.
they're like, what? I'm going to do a right IJ and a
We
renal.
want both.
No, we're only pick one.
This is endocarditis, we got
Endocarditis.
it.
Okay, so it looks like most people are saying 4, and you are absolutely correct. What about a 4-day-old? They have a UVC, a UAC, and they're having apneic events. Where are you going to draw your culture? Okay, peripheral. You guys are going to stick this baby? They have access. It's a 4-day-old.
So did the 17-year-old.
I mean, pediatricians are supposed to be nice.
But the policy probably isn't.
Okay, so it is peripheral. So,
So Linda,
yes.
so I'm trying to figure out whether my thinking is just old or whether we're talking about different issues.
Okay.
So in my mind, that 17-year-old, I need to understand, because I need to manage this catheter, whether that organism is in the line or not. So for your definitions, 4 works. But if I if I had a negative peripheral and a positive line culture, then I would say, oh, that's in the line. And maybe that line needs to be TPA, needs to be taken out, needs to be whatever.
Okay.
Versus if I had it in both, then, you see that? So do I need to just say, no, I'm not going to culture lines anymore, I'm just going to do peripheral? Or am I talking about a different subject in management?
Yeah, so it's excellent questions and really good points. So I was always trained, if they have a line, get it from the line. You want to know if that line is infected, you want to know if you need to remove that line. And we're pediatricians, right? So don't poke the kid already. They already have line, they have access, just get it off of them. And so I was always trained that way. I've always said, triple lumen IJ. Get a culture off every one of those lumens. If they're looking really sick and I am just like, oh my God, I'll even pull it off of their arterial line. I'm just like, I just want to know where this infection is coming from, to treat it. So that's how I was trained and how I've been practicing. So it turns out there's some really good, solid evidence that you get the rate of false positives pulling off of a line is super high. And your risk of contamination and not having a true infection is really, really high if you pull off of a line. It's, you really, really don't, I never pull it off of a PIV. You should only pull it off of a line if there's no other way you can possibly get.
One of the practices I see the nurses do with a patient that needs IV access and a blood culture is to clean the area and use the IV catheter to get that blood culture so that you kind of do both with one, which makes sense.
Yeah.
But if it's from contamination of handling too many pieces, would that be still be a higher risk?
So I don't know the answer to that because what I was looking at, I didn't see anything that talked about pulling off a brand new IV that went in. I do know that, if I'm throwing in lines and this kid is really sick, I'm going to pull off the line too, and I think that from what I've been speaking to, like in the NICU, they will do that too. Like their initial cultures on a newborn, they'll place the line, the umbilical lines, and they'll draw cultures off of the lines. I think if it's brand new, your risk of contamination is going to be less. But the actual policy, and we looked at, I think Shelby did this, our infection preventionalist, looked at other children's hospitals, and nationwide, Henry Ford, Children's Mercy, CHOP, all of them, their policies all say, do it peripherally, even if they have a line, if you can possibly do it. And it's really because of the high rate of colonization. Now, to speak to Dr. Key's point, if you have a bacteremia, which is really what we're testing for, right? Not so much eclampsia, we're just like, oh yeah, their blood is infected. Then you're likely treating through that central line. You're probably going to remove that central line as soon as you can. You're probably going to replace it with something else if you can anyway. And so I think they're like, if you've got a bacteremia, the chances that you've seeded this line wherever it is going to go up. And so you're probably going to end up removing that anyway, if you can. Did that answer your question? I don't think that it's wrong to, the rule is to always get two different sites, right? If you really are looking for a blood culture results, you want to get two different sites, and so the recommendation is 2 different venipunctures. If you're, we're in pediatrics, so I would say a peripheral, and then if you do want to pull off the line to get more information, it's, but what are you going to do if the line is positive and your peripheral is negative? Is that colonization for that line? Can you leave that line in? Should you be removing that line?
But it's interesting to look, nationwide says that you shouldn't draw if it's impossible or if you think you have a class, right?
Yeah.
And then the other 3 say just never do it.
Yes.
Which is fascinating.
Yeah.
So the way you do triple lines, you draw off all 3 ports.
Yeah.
You don't do that anymore, right?
I don't do it anymore. I try to do venipuncture, and I never do all lumens anyway. Even if I do have no other option and I need to pull it off, I don't pull all 3 lumens. I'll try to do 2 different spots. If I have an art line, I might do off the art line, but yeah, it's best to do a venipuncture. So you have a 5-year-old, forward 25, weaker with a DIVA score of 7. Does everybody know what a DIVA score is? So this is difficult IV access. So, and I should have put the little table up there, but the younger you are, you get a number. So if you're over 3, you get a 0. So it's if they can feel a vein or if they can see a vein, gives you different numbers. If you're premature, you get numbers. So the prematurity gave this baby, I think, a 3. And then not being able to see the vein and not being able to feel a vein, each gave them 2. So DIVA score 7, so that's high. So anything over 4 means that they are difficult IV access. It's a really important number. Our nurses should be doing it and testing so that it informs you a lot. Like, am I going to be able to do I need to get a PICC line instead of having people try 15 times for an IV? Are they going to be able to be stuck for anything if something happens? So they have a PICC line, new onset fever. One, 2, 3, or 4. Guys are all right. Come on.
2 is the perfect answer, but 4 is the real
I'm
answer.
gonna try.
We've got some 2s and some 4s. Okay, the answer is 3. The reason why is a DIVA score of 7, like, you're not going to find a vein. So it's not even worth torturing this child. Just draw it off your PICC. And make sure that the nurse labels it, that it's a PICC line, so that we know, this may actually be contaminant, it might not be real, but there's no need to torture this little 5-year-old. Okay, use your clinical judgment. Oh, sorry, I skipped over that. So in essence, really, the thing is, use your clinical judgment, do right by your patients, because our goal also is to not cause undue suffering. So do right by your patients, but if at all possible, try to not draw off your line. Okay. So again, similar to our CODIs, you want to discontinue central line as soon as possible, and then we have insertion and maintenance bundles. Our current CLABSI rate is 0.497, which is in the green. We're in the top percentile. It's lower than the SPS central line. And we've actually, we've had 1 CLABSI in the NICU in the past year. I think in October, we're 3 years from having our last CLABSI in the PICU and 5 years from having it on the PEDS floor. So, and hopefully we'll start tracking from an outpatient perspective too and get some numbers there. But, okay. So we used to worry about VAPs, ventilator-associated pneumonias, where it's now been changed to ventilator-associated event, or PED-VAE. And so we're going to go through the lovely definitions for this. Okay, 4-year-old intubated for 4 days with a new infiltrate on chest x-ray, but no change in oxygen needs. Is this a VAE?
No.
Your intensivist said no. She is right. We do not look at chest x-ray findings. They are not part of the definition anymore. So a ventilator-associated event can be associated with infection, so pneumonia, sepsis, ARDS, but it also can be pulmonary edema, pulmonary hemorrhage, pulmonary embolism, barotrauma. It does not have to be infection. So these are this is what entails. So any of those things qualifies. And so it's not at all based on your chest x-ray findings any longer. 2-day-old intubated since birth with worsening oxygenation.
Has their oxygenation status been stable until day 2?
Oh. You might not be allowed to speak anymore. I'm seeing some no's. Yes, no? No. No. Okay, so you have to have stable ventilatory vent settings for more than, so again, CAUTI, VAE, more than 2 days, CLABSI, 2 days. You have to be intubated for at least 4 days. So you have to be intubated for 4 days and stable for at least 2 of those days before the event happens.
And how did they define stability by not changing your peak?
We will talk about stability. Yes.
So, person on the vent for 5 days,
Yes.
valve sepsis, and then ARDS have been stable.
Mhm.
So oxygenation is going up, PEEP's going up. So is that would that be an event?
Yeah,
Then,
it would be. Okay, so stability for pediatrics is defined as FiO2 or MAP, so mean alveolar pressure. So it has to be either stable or decreasing for more than 2 days. So you have a 15-year-old intubated for 1 week, so you meet your first criteria. The respiratory therapist has now increased your FiO2 from 0.25 to 0.5, or if you prefer, although not correct, 25% to 50%.
Why?
Is this a?
Why did he do that? Or she do that?
Well, probably not because they were bored. I'm assuming the child was desaturating.
Yes.
So we're saying yes.
If he's unstable.
So it really depends. So you have to define what this actually means. So they're looking at your daily minimum for each day. So they will go through, your infection preventionalist will go through all of your recorded FiO2s and MAPs. And you have to, and they will count the lowest FiO2 that's documented within that calendar day that's maintained for more than an hour. So if it's documented at 0.25 for at least 2 hours, that's going to be your minimum for the day if it didn't go lower than that. And same thing for your mean airway pressure. If it's less than, except that if you're less than 30 days, 0 to 8 counts as an 8. If you're more than 30 days, 0 to 10 counts as 10. So the lowest they will ever record if you're 10 days old is an 8. And if you're above 30 days old, the lowest they'll count as a 10. Okay? So now we know that he's been intubated for a week. His lowest minimum FiO2 for 3 days in a row has been 0.25, and the RT increased it from 0.25 to 0.5. Yes? It still depends, because you have to have following happen. So this is your third criteria. So you have to have an increase in your FiO2. It can't just go up by 0.5. It has to go, or sorry, 0.05. It has to be greater than or equal to 0.25. And then, or your MAP has to be greater than or equal to 4 increase. So you have to be intubated for 4 days. You have to have a period of stability for more than or equal to 2 days. And then you have to have an increase either in your FiO2 of greater than 25% or an increase in your MAP of greater or equal to 4. Okay, so now we have all the information. 15-year-old intubated for a week, was at 0.25 for 3 days, RT increased it from 0.25 to 0.5. Is that a ventilator-associated event? I see heads nodding yes, it absolutely is. 10-year-old intubated for 3 days, overnight mean increased from 8 to 3, or sorry, 8 to 13. You say no, why?
It hasn't been more than 4 days.
So it's not been more than 4 days, and was the MAP criteria met?
Yeah.
Yes, you said no. Why?
Because he's 10.
He's 10, so
So
the
that would
minimum
be-
MAP they count is
10.
10, so it only went up by 3. Yeah, so we missed 2 criteria there. Not 4 days, and the MAP only increased by 3. Okay. So now you have a 6-day-old intubated since birth. These are those 6 days. Is this a VAE?
Yes.
Why?
The FiO2 increase of 2 days.
So you had, so it's been more than 4 days intubated. We had a period of stability here, right? 0.4, 0.4 for at least 2 days, so greater than or equal to 2 days, and then it increased by greater than 0.25. So yes. 3-year-old intubated for 6 days.
No.
Why not?
Age and MAP increases not to the criteria.
And was there,
Not really a time of stability of the FiO2.
You haven't had 2 days with consistent improvement or stability.
so you had no stability really in your FiO2, but you did have 2 days of a MAP at 9. So then you'd have to focus on your MAP, and that didn't go up high enough, right? It's less than 4.
So when you say there's no stability in the F5-2, there's clear improvement from day 1 to day 2 to day 3. Right?
There-
So that's not stable, but that's going in the right direction, right?
Right. So you're saying this, so stability or improvement, which is one of the definitions, yeah, so you could say that. But then it didn't, how do I say this? So there was 2 days of stability, but then it only increased, so then you look at your daily minimum, and this day it didn't go up by enough. This day it did, but there hadn't been stability before that. Does that make sense? So those days of stability needed to happen before,
Adjacent to it.
adjacent to it, like consecutively. So improvement, not worsening, but not by greater than 0.25. Worsening greater than 0.25, but not after 2 days of stability.
So if they hadn't leaned to 35 and kept it at 40 on day 3, then you would have had 2 days at 40, and then the 70 would have.
Yeah, if they hadn't done this little thing here, then you would have had some stability and maybe it would have qualified.
You could have a therapist that just,
Yep, you
Yeah.
sure can.
And you can have a hospital policy that you change your FiO2 or your PEEP every day by 1 or 2 points, and you never have stability.
Yeah, so we actually had a patient that I was convinced had a VAE. We intubated 17-year-old, getting better. I was ready to extubate, and then he woke up from his sedation in the middle of the night, coughed. I'm assuming it was a cough, but spontaneous spontaneous or whatever. Anyway, pneumothorax got significantly worse until that was identified, treated. I came back on the next morning. His MAP had gone from 8 to 22. His FiO2 was 100%. or 1, if you want to be more correct. And then I was able, and then I weaned throughout the day. And I was just like, this is a VAE, and I was arguing, and they came back and they showed me everything, and they're like, it's the minimum. So I had weaned him so quickly the next day that within less than 24 hours, he was back down to where he was before. So not a ventilator-associated event. Did we cause it? Probably. But it didn't ding us. So, same type of primary and secondary intervention. Our VAE right now is 0.103, but we just had another VAE in the NICU. So I'm not sure if we will be above the center line after this next month, but currently we are below it.
In our notes, we should not declare something a ventilator-associated pneumonia, and I've seen
No, you
residents
shouldn't,
use that
because
phrase.
you're not looking at all the data.
No.
Right, yeah. And even when you know the definitions, you still get it wrong. Like, I mean, I was arguing with them. I'm like, no, this kid definitely had a VAE. Yeah, it wasn't. So I'm just gonna go quickly, as quickly as possible, because we only have 4 minutes.
And do VAEs happen in trach patients?
Yes,
They
it
used to
still
not.
counts, I
The
believe.
FAAPs didn't.
That's a good question. I'm not gonna answer that.
Okay.
Let me go back. I don't think they count, but I'm gonna have to check on that. So really quickly, just going through our data. So average stroke events, there's categories A through I. A being like, there was an error made, but nothing bad at all happened. It didn't even hit the patient, but there was a capacity for it. I being the patient died from this particular error. So we only have to report E through I, so those are the ones that actually reach the patient and could potentially cause harm. But as you see, there's a whole bunch of other errors that could still happen that we just don't report on. So we actually are in the above the center line for our E through I's. I didn't put our actual number here, but really the most important thing to do is just slow down and just slow down. And I know that's really hard for all of us to do, but the majority of our medication errors are because the physicians or nurse practitioners write the order wrong. So it's on our side and it just doesn't get caught. So I think at a faculty meeting a little bit ago, I had one of our pharmacists present that just to kind of get that message across that we are causing the majority of the errors. Falls are reported to SPS. That we track falls with injury and falls without. We're below the center line with injury, and falls without injury, we are way above the center line. As you can see, we're 0.4, and we just had another one, so that number is going to go up. And the center line is 0.1. So we have a project ongoing to try to decrease this. We're following yellow Humpty Dumpty signs, yellow wristbands on our patients, and a yellow light outside the room. And then our next intervention is going to be hopefully the one that makes a bigger difference, which is getting parents more aware of the risk of falls in a hospital for their child so that they can watch them a little more closely. We also follow unplanned extubations. Our current rate is, as you see, really above the center line. I think we had in one weekend 5 unplanned extubations in the NICU. That happened to 2 patients. They just kept pulling their tubes out. A little baby. So we are working on that. We just recently met with the University of Pittsburgh Medical Center, who is a high-performing center in unplanned extubations, to just kind of talk to them. What do they do? How do they prevent this? How do they have such good numbers? And we're implementing some things to hopefully improve that. Our pressure injuries, we've had actually only 2 this year, but that it was enough to throw us over the center line for SPS. So we've done deep dives and trying to get our 2 pressure injuries have been on neurosurgical patients, and so trying to get some input from the adult neuro ICU, which has not had a pressure injury in a long time. The problem is they come craniectomies and they don't have their bone in, and so we don't tend to rotate them quite as much, and they've gotten pressure ulcers. And then just some other interventions that we're trying to do. So we've developed a respiratory safety committee so that we're following VAEs and unplanned extubations. Dr. Ward and Amber Lipes is in charge of that. Those are our co-leaders. We have revamped our vascular access committee. We're working on PIVs, some aseptic PIV insertion techniques, and hopefully getting our CLABSI bundle put into EPIC in the next couple of months. We've also revamped our medication safety committee. Carrie and I are conducting safety rounds. We've gone around and focused on patient harm for our first time around. We're now just starting our second round. We've done inpatient so far, looking at staff harm. And then I wanted to just throw in our newsletter, which has some really great little tidbits, a safety corner, a QI corner. But the important thing is this challenge that we do. So you'll see that picture. This was the one that we did in July. We've done safe sleep pictures and car seat safety. So we show you a picture of something that's absolutely wrong, and you just have to go in and identify. There's a little QR thing. You go in, put it on your phone, answer what you think is wrong with the picture. The first person to get it correct gets this beautiful, amazing t-shirt, which says, keep one child safe, you're a hero, keep hundreds safe, you work at Carilion Children's. And so far, we've only had one physician answer it one time. So I would really like for the physicians to get a little more involved in that, because I think we can find things that are wrong with the picture as well. So just keep, the next one's coming out this month, so keep your eye out, do it. I think it's fun, and you get this really cute t-shirt.
I wore my t-shirt last week and got a lot of compliments and asked when they had ordered them because they'd missed the order.
Yes, everybody wants, they're like, I want it. I'm like, you have to earn it.
It's a pretty color.
You have to earn it. Just like when we do safety rounds, we don't just hand out little treats. We go with treats, but you have to earn the treat by answering some questions. So everything is earned in my world. So questions, comments? So sorry I went 2 minutes over. Yes.
Is there an outpatient equivalent to these kinds of safety monitoring activities amongst children's,
Yes.
especially
So
hospital programs?
as you can imagine, the ambulatory world is much more difficult to do and to track. They're working on tracking medication. We are tracking medication errors. We're trying to get our safe watches up. And then SPS is rolling out this year a big ambulatory program for quality and safety work. And we're going to be working on that. We're joining it, and hopefully we'll have some things going through.
And are they developing an AI program to plunk this data into and have it come out with the correct answer?
Oh, I wish. That would be really nice, wouldn't it?
'Cause it sounds like it's maybe a full-time job for them.
Yeah, it's complex. Yeah. Okay, great. Thank you.